Welcome, my dear audience and friends, to Cancer Convos with Grace B. This is your host, Grace B, coming to you from New York City, the city that never sleeps and is home to Cancer Convos with Grace B. For the newbies, this show aims to demystify the cancer disease and to seek experts and stakeholders in the cancer space to come give their take. As we all know, cancer happens to everybody, and so what I usually harp on is prevention is better than cure. So, for those of us who have, undergone a mastectomy after breast cancer diagnosis, questions usually arise as to what to do post-surgery. Many options abound as to whether to go flat, whether to have implants, and all other options. But that is why in this episode, I'll be having my amazing guest who has carved a niche for herself in this regard. She is founder and director of a 501c3 nonprofit organization offering information to patients about all options of breast reconstruction as part of their breast cancer treatment. Therefore, without spilling too much of the beans, as this promises to be a very loaded conversation, let me welcome Terry Kuti to the show. Welcome, Terry, and thank you so much for the privilege of your time.
Oh, Grace, thanks for having me today. I've been very excited to speak with you about this after we had our initial warm-up introduction, and just talking to you felt so comfortable, and I'm excited to share some information today. Thanks for having me on the show.
Oh, it's such a pleasure and honor to have you with me. So, before we delve into
Thanks.
the nitty gritty of this very important issue, please tell us a bit about yourself.
Yeah, so I'm a two-time breast cancer survivor. My first diagnosis was in 2002, and at that time, the standard of care where I was treated, which was at a large medical facility in Houston at MD Anderson Cancer Center, was to do two lumpectomies. And I did that because they didn't get clear margins the first time. That's not unusual. That happens, quite frequently to women and men who have been diagnosed with breast cancer. After that, because of the biology of my tumor, it was suggested for me to go through 18 weeks of FAC chemo, which was fluorouracil, adriamycin, and sin. So a pretty heavy dose of chemotherapy, which made me sick. I landed in the hospital with a neutropenic fever, lost all my hair, many things that women sometimes don't go through when they go through chemotherapy. It was a little bit of a rough road for me. And I got a break for about 6 weeks. And then they did very targeted radiotherapy to my left breast. That was where the occurrence was in 2002.
Mhm.
I then took 5 years of tamoxifen because my breast cancer was ER/PR positive. So the tamoxifen was to suppress the estrogen receptors that were feeding the cancer. Took that for 5 years, got my strength back. We moved to Tucson, Arizona in the US. I finished my tamoxifen. I was back in school to get my master's in teacher leadership. My husband was overseas on a proposal, and we were, as they say, riding the wave. And the wave came crashing down in April of 2014 when I had my second breast cancer diagnosis. I had a recurrence and I had a new primary in my right breast. So now I had to go to my breast surgeon and discuss with her if she was going to remove 2 body parts, both of my breasts. It's an amputation. I believe that. I call it what it is. It's lost body parts.
Mhm.
And oddly enough, Grace, when I went into the consult, I thought that I would be living flat the rest of my life, and I had accepted that. Because then in 2014, I had no knowledge of the information I have now. I had no understanding that there was options for breast reconstruction. But because my breast surgeon was very well informed, very, very highly trained, great credentials, and well connected, she told me all of my options for breast reconstruction. That day, the same day she told me she was going to remove my breast. In my humble opinion, I believe this is the conversation that all women and men should be having if they're told there's the possibility that they're going to lose their breast. It doesn't mean you have to choose reconstruction, but I believe that the option should be given, because what that did for me in a moment of anger and fear and frustration that my breast cancer had returned, facing loss of breast, this gave me a sense of hope. And she presented the material to me in a very methodical fashion. She did take it home and she said, I want you to think about if you would like reconstruction or not. Because of her schedule, because of my mental anguish having breast cancer twice, I didn't want to spend the time to search for a microsurgeon, because the ones that were in my area, they didn't meet my criterion for what I would want for microsurgery. So the best advice I can give to women is, and men, if you're facing a mastectomy, one of the first questions you should ask is, how long can I wait to have my mastectomy? Because I may have been able to wait. I just don't know now, and that's water under the bridge.
Mm-hmm.
And as it turns out, I found an amazing microsurgeon to do what I chose to do for reconstruction, and that's DIEP FLAP. We can talk about those options later.
Yes, yes. Because I just slightly want to take you back so that we can walk with
Yes.
you. Um,
Mhm.
Prior to your diagnosis, I want to take you back to if you to ask if you had any symptoms or whatever to warrant having breast cancer prior to your diagnosis.
That is a great question to ask, because the first time I found it myself. So, yes, I was having symptoms. The only symptom I had was a small pea-sized nodule close to my axilla in my left breast. And it was a very distinct feeling hard lump, very small, but it wasn't there before. And I was very diligent about doing my monthly self breast exams, Grace, which you know are very important. And you've talked about this on your program. So that's what I would like to send today, is for women to be able and be sure to do your monthly self breast exams, men too, because men get breast cancer. And yes, those were my symptoms. I felt the lump,
Mm-hmm.
but at the time we were in transition, moving from one city to another. And I had to establish new care when I went when we moved to Houston and established care at MD Anderson. The second time I found breast cancer, it was a little different. I went to my primary care doctor at the beginning of January just for my regular exam, and she knew my breast surgeon. They were friends. So she was very in tune with my history. She did a thorough palpation of my breast, thorough breast exam. She didn't feel anything. I didn't feel anything. About the March timeframe, I scheduled a mammogram. And a couple weeks prior to that, I felt a little bit of a thickening in my breast, But I had been going back to the gym and working out pretty rigorously on weights. And in my mind, I dismissed it as it's probably just, some tissue that's a little muscular or something. And I also told myself, I says, well, besides, I've got my mammogram scheduled in 2 weeks. So I had my mammogram like right at the end of March, beginning of April. I can't remember the date now. And sure enough, that thickening was a new primary in my right breast. So it was a surprise. I think it was a real surprise that I had that recurrence. So I guess the message is, 1, do your breast exams every month, and 2, don't ignore any kind of different feeling that you have in your breast. I don't think, even though I felt it a couple of months prior to my mammogram, my primary care surgeon told me, she says, don't beat yourself up about that. We caught it and we're going to treat it now and it's going to be okay. So,
Oh,
yeah.
wow. That must have been, I mean, twice. Anyway, I've met one or two friends of mine that have been diagnosed 3 times. So even once is a bit too much, not to talk about 2 or 3, So that is scary. But
It is, but it is. And it doesn't get easier,
mhm,
anytime you hear those words, but the body has a lot of resilience and we've come a long way in the way we treat cancer, and our
yeah,
survivability.
mhm,
We're not able to save everybody, as you know, Grace, but I
I
think it's
know.
come tremendous leaps and strides over the last few years.
Yes, indeed. And very few are dying from breast cancer, nowadays, you know. Um,
Yes. Unfortunately, too many, but even in the metastatic community, I'm so proud of that
mhm,
group for stepping forward and working
mhm,
hard
mhm,
to bring recognition and also to do more research, clinical trials in that
mhm,
regard. So
mhm,
yes,
mhm, mhm. That's
yeah.
great. That's very good to know. So, as founder of your foundation, tell us a bit more about what you do, and what you would say are the options for a breast cancer reconstruction when anyone is diagnosed.
Yeah, so while I was recovering from my mastectomy, as I told you before, because of scheduling, my fear that had come back, I told my breast surgeon, take them off. I will find a surgeon after this. I'll do my research. So I did. She didn't give me a whole lot of information on DIEP FLAP, but she told me about it. She gave me information on implant reconstruction. I read all of that. Then I began researching about DIEP FLAP. After I fully understood what it was, and after she told me about it, I don't know, just the mufflers went on. I'm a bit of a purist.
Mm,
Myself, I wanted to use my own tissue. Not everybody makes that decision. So flap is this is part of the information to answer your question too,
mhm,
Grace. This is all part of the information that Deep Sea Foundation works to educate women and men about. So deep flap, it's considered the gold standard in autologous reconstruction. Autologous is a word that means using your own tissue. And there are more than one parts of the body that flaps can be taken from, as long as they have a good blood source and as long as the surgeon is skilled in that particular method.
mhm,
But back to deep flap. That is the gold standard because the tummy tissue is most like the breast tissue. And also it's at the front of the body. There are other flaps that are on the side of on the inner part of the thigh. That's a tug flap. There's a pap flap, which is a posterior uh, flap at the back of the buttocks.
mhm.
Takes a little more turning on the table, but the deep flap is right at the front. It's the
Mhm,
lower abdominal tissue. And so what they do is they take the skin, the underlying tissue, and the blood vessels. They do not take the muscle, which is very beneficial because once you take the muscle, there is oftentimes a higher risk of hernia. A woman loses her sit up muscle. So it makes it very difficult to do any kind of activity that would require that sit up or rectus abdominis muscle.
Mm-hmm.
So they literally disconnect the tissue and the blood source. That's the deep. It's deep inferior inside. Epigastric is the abdominal area.
Area.
Perforators are the blood vessels.
Mm-hmm.
So they disconnect that and they reconnect it to the main mammary artery up at your breast site. And this is done through a high-powered microscope. So plastic surgery, microsurgery falls under the category of plastic surgery. Plastic surgeons any plastic surgeon can place an implant into a woman, but not everyone can do microsurgery. That takes specialized training, more years of,
Specialization
practice.
and practice.
And
Yeah.
yes, that's exactly right, because they have to learn to anastomosis is the tying together blood vessels
Mm-hmm.
with filament that really is as fine as your hair. So they're looking under these high-powered microscopes, tying these blood vessels together. What you end up with is soft, warm breast tissue.
Mm-hmm.
And there are surgeons now, this is part of the development that I've seen over the years that I've been doing the foundation work. There are more microsurgeons now who are truly interested in restoring sensation and feeling to the breast. So, along with the blood vessels, they also look for the damaged nerves that have been cut during the mastectomy, and they look for a nerve in the tummy area, a viable nerve. They transfer it up, connect it to a nerve along the intercostal plane of the breast, which runs inward toward the nipple area.
Mm-hmm.
And so they're able to reconnect nerves too. So, the advancements in microsurgery I have seen, even some since I've had mine in 2014. The other type of reconstruction that you can have is implant reconstruction. And Grace, that's what most women choose.
Mm-hmm.
I think it's because many women think that it's an easier surgery because you don't have the abdominal scar. Some women choose that surgery because they don't want the abdominal scar.
Mm-hmm.
Others choose it for reasons, maybe they want a larger breast and the flap that they have isn't going to provide the projection. So if that's the case, you can also do what the third option, which is like a combination where you do implant surgery and then you also use some type of autologous flap surgery in combination with that.
Mm-hmm.
So you have the flap surgery over the implant, and it gives you that softer, warmer feeling. So basically there's implant, autologous, and a combination of the two.
Yes, and also I realized that I had these options availed to me, and I realized that for people that are slim, you know, the deep flap is not usually recommended for them because they need to have that fat either in their abdomen or their inner thigh or whatever. So most probably you see you find that a lot of women are relatively slim, and maybe they may not. They would actually opt for saline because okay, I'm slim. They said I need a bit more fat, and that I cannot produce in such a short time. So these two, because the deep flap, you need to have some kind of body, some kind of tissue to really make sure that this is successful, right?
For the most part, yes, Grace, but here's the thing that I want to add to that.
Mhm.
It depends on the surgeon's skill. There are surgeons who are able to take more of an extended flap kind of around the waist. There are surgeons who are able to do stacked flaps,
Mhm.
and it's all autologous tissue. Just because you're a slender woman and have a low BMI doesn't necessarily mean you're not a candidate for DIEP flap. I know women that have, a low BMI who are considered athletic and slender, and yet they have been able to achieve a very soft, warm, natural breast from a DIEP flap. But
Mhm.
it really takes a surgeon who is skilled in doing that and has done it frequently and is used to using everything you've got
Mhm.
and just being able to form it properly and everything. It really has a lot to do with surgeon skill and their expertise and how many times they've done surgery. And also, are these surgeons looking at optimal ways, inventive ways to try to optimize this tissue, if that makes sense?
Yes.
So, yeah, just because you're a slender woman does not necessarily mean you're not a candidate for DIEP flap. Now,
Yeah.
realistically speaking, sometimes if a slender woman had large breasts before her mastectomy and she still wants to have a DIEP flap, she may not have the same size. And so that's part of the discussion that needs to come into play with your plastic surgeon. Patients need to set realistic expectations based on their body habitus and what the plastic surgeon can, produce for them.
Can do. I'm very happy about that information, Terry, because a lot of women feel that, oh, because they're slim, they may not be good candidates for that particular option, the deep sea flap. So now that
Mhm.
you have now explained it fully, that it only depends on the expertise and experience of the surgeon, then anything is possible. They could be candidates, good candidates for it. So that's good
They
information to put
could.
out there. Yeah.
Yes, yes, and I think, Grace, it's important to point out here, women and men who are considering breast reconstruction,
Hmm.
I really like to empower them that it's okay to get a second opinion.
Hmm.
Just because, you might go to a plastic surgeon who's extremely skilled, a microsurgeon who's extremely skilled, but they haven't gone outside of that realm of, what the possibilities are and practicing, using all the optimal tissue there is to create a breast. Um, so, yeah, it is
Oh, that
possible.
that is awesome. What would you say is the most common form of breast reconstruction?
It's definitely implant reconstruction. And I think the reason that is, um, like I said, I think many women think that it's an easier surgery or they just don't want to go through the difference in recovery. For DIEP flap, it's around 6 weeks. For implant surgery, I think they say it's roughly around 3 to 4 weeks.
That's
And some of them
recovery,
just,
right?
like I
After
said, don't want.
you mean
Mhm,
recovery?
mhm,
When you say
mhm,
3, 4 weeks, is it recovery after surgery?
mhm. Yes,
Okay.
yes. And around 6 weeks for the DIEP flap, which is surprising to many people. There is a protocol that has really gained a lot of robust interest in major surgical groups across the country called ERAS, and it's called Enhanced Recovery After Surgery. And for DIEP flap patients, it has been a game changer because it has decreased the use of opioids. they carb load a patient the night before surgery, the morning of surgery. I was in hospital for 5 days. Now, I was an out of town patient, so they kept me a little longer, but I didn't have ERAS. They enacted it, about a year after I had my DIEP flap. But now I really, really tell women, to ask if your center is using it, because it decreases the use of opioids.
Right.
It gets you back on your feet and gets your body moving quicker, naturally. You're eating food quicker, your catheter is out earlier. They're going home in 2 days after
Wow.
surgery, after DIEP flap surgery. So it's pretty impressive.
Mm-hmm. So
Yeah.
with all this, something that bothers a lot of people, and also what I had to think of post mastectomy was insurance. So
Mm.
were you covered by this, and what advice would you give to that person whose insurance doesn't cover this, but any procedure whatsoever at all regarding breast reconstruction?
Well, to answer your first question, mine was fully covered. I felt very fortunate that we had very good insurance coverage, and the center that I went to took most major insurances, so I didn't have that bridged across with that. But I'm so glad you brought this up, Grace, because there is a law that went into effect, and it's called the Women's Healthcare Cancer Rights Act. It was in 1988 that they passed this. I often call it the Wicker. Some people call it the Wicker just because of the acronyms that are used, the WHCRA.
Mm-hmm.
But I wrote down, because you sent me that told me that you were going to ask me this.
Mm-hmm.
I wrote down what it says. If you are receiving benefits in connection with a mastectomy and you elect breast reconstruction, coverage must be provided for all stages of reconstruction of the breast on which the mastectomy has been performed. Some women have bilateral, some have unilateral. Surgery and reconstruction of the other breast to produce symmetry. So if you had a unilateral, they might need a mastopexy or a reduction to achieve symmetry. So that should be covered. Prosthesis and treatment of physical complications of all stages of the mastectomy, including lymphedema. But,
Yeah, always.
here's
It
the
can't be so.
caveat. Yes, exactly. There's really two different types of coverage, at least in the US. There's something called group health plans,
Mm-hmm.
and that's provided by your employer or your union. And then there's individual healthcare policies. So that's not based on employment. And the thing is, Greg, that when women, sadly to me, when they are faced with this emotional barrage of information and a diagnosis, and they have to go and fight insurance companies on getting something approved like your breast reconstruction, I feel so badly for them. But it happens, Grace. It
Mm-hmm.
happens. And the reason it happens is because some women, their particular insurance carrier might not be something that a practice they really want to go to carries. And there are just other caveats too. So my best advice, if this happens to women,
Mm-hmm.
take a deep breath and ask for help. Ask for help from the center that you would like to go to. Ask to speak to someone in their insurance department. And I'm telling you, it takes patience on both parts, because I know that there are providers that just spend hours on the phone with insurance companies. There are physicians who write letters on behalf of their
Patience.
patients. So be patient and just be quite honest with the insurance person at the, either at your insurance company or at the practice you want to go to and say, this is so overwhelming to me. I want to understand why I can't get this procedure covered,
Mhm.
but I really need your help. So let's be patient together and see if we can get this problem solved. Sometimes it's just a coding issue. It's
Yes,
nothing more than a coding issue, and they're able to work it out. Other
yes.
times, they truly do have to go to and find someone else. So I'm glad you asked me that question.
Yes, and I'm very happy that you were able to find out about this wicker thing because I'm sure a lot of people don't know about it. There are a lot of laws and
Mhm.
acts that are kind of, you know, uh, I wouldn't say hidden. I don't want to say that. But if you don't search for certain types of information, you don't find. And this could actually be some leverage for people to actually look into and see if this would cover them when going through something like this.
Yes.
Yeah,
Yes, just go to WHCRA 1998 and you should be able to find the information, or look up Women's Health Care and Cancer Rights Act of 1998 to get the verbiage. And then at least you have the wording and can try to help you understand what the caveats may be for you, and how to talk to insurance about that.
absolutely. This will be in my
The
show
other thing
notes as well. Yes. Go
okay,
ahead.
good, thank you. The other thing I might add, Grace, is that one thing I do tell women, if you do have to travel for reconstruction, which I did, um, start thinking about saving a few bucks for that and saving some money for that, because your air travel is not covered, your food and lodging is not covered, but at least when I had my surgery, I could claim all those as medical tax deductions. So keep
Hmm.
your receipts, keep all that information so that perhaps you can at least turn it in for medical tax deductions, and that helps.
Absolutely. That's fantastic. And also I
Mhm.
remember when I was going for my interventions, my insurance covered my transportation. So I didn't have to like that was like, initially I was using a lot of Uber, you see. So I now had to start asking questions. I mean, for 24 months, am I going to be paying out of pocket expenses for Uber, until a lovely lady told me, you are covered. Just go here and go there. So it's good to ask these questions, because a lot of people don't know that, certain things can be covered by your insurance. So that saved quite a bit, a bit of money
You
in
know
that
what?
regard. Yes, Terry.
You're a wise woman, Grace.